Good morning. I'm Mike Friedman, the 113th president of the National Press Club. I am journalist in residence at University of Maryland Global Campus and executive producer of the Kalb Report public broadcasting series. This morning, we welcome Dr. Anne Schuchat, Principal Deputy Director of the Centers for Disease Control and Prevention, which has been closely monitoring and responding to the outbreak of respiratory illness caused by the new coronavirus, first identified in China. As of this morning, Chinese officials report more than 1,000 deaths and more than 42,000 current cases of coronavirus. More than 7,000 of the affected patients are reportedly in critical condition. The death toll has now eclipsed that of the 2003 SARS outbreak. One American patient died in China over the weekend. The CDC is now evaluating more than 400 people in some 40 states and territories. Here, so far, 13 have been confirmed to have the virus. While the outbreak has been designated a public health emergency in the United States, and imported cases in travelers have been detected with some person-to-person spread among those with close contact of returning travelers from Wuhan City. According to the CDC, the virus is not currently spreading in the U.S. Over the course of her distinguished career, Dr. Schuchat has played key roles in the CDC's emergency responses to the 2009 H1N1 pandemic influenza response, the 2003 SARS outbreak in Beijing, and the 2001 bioterrorist anthrax response. Dr. Schuchat has also worked on meningitis, pneumonia, and Ebola vaccine trials in West Africa and has conducted surveillance and prevention projects in South Africa. Following her remarks, we will take your questions from your seats. Lindsay Underwood will bring a mic around to you so you can ask your questions on mic. Dr. Schuchat, thank you very much for joining us. The podium is yours.
Well, good morning, and it's a real pleasure to be here. Thank you for inviting CDC to this Newsmaker event and for giving me the chance to provide some remarks. What I'd like to do today is provide an update on the situation with the novel coronavirus outbreak, as well as some reflections on this outbreak in the context of other emerging infectious diseases that we've had to deal with, and the US CDC's efforts to prepare, prevent, and respond to this type of concern. So to borrow a phrase from Tolstoy, happy families are all alike. Each unhappy family is unhappy in its own way. Emerging infections, including novel respiratory pathogens, are each unfortunate in their own way. So while we have learned from SARS and MERS and both avian and swine influenza experiences, and from each of the major influenza pandemics of the last 100 plus years, each had a different impact. Encountering the emergence of the novel coronavirus spread in 2020 has been challenging and reminds me to be humble. We plan and strengthen our preparedness efforts here and around the world, and these efforts are very important. We try to avoid the problems of the past and assure that there is capacity to find, stop, and prevent outbreaks at their source, and work together as a global community when any individual nation's resources are overwhelmed. That's the very essence of the global health security work ahead of us. But each new emerging infectious disease can present us with surprises and new chances to improve our response and prevention efforts. The current situation with the novel coronavirus is dynamic. There are very different circumstances in Wuhan and Hubei Province, China, than in the rest of mainland China, and very different from in other countries around the world. The circumstances in the different settings require different responses, different intensity, different strategies. Here in the United States, as you heard, we have 13 confirmed cases of novel coronavirus occurring in 6 different states. We have active efforts to find and evaluate people who are under investigation as possible cases, and we're supporting state and local public health to investigate those individuals, and when cases are confirmed, to do contact tracing and understand the spread that has occurred or that might occur around each one. Of the 13 cases here in the United States, 11 occurred in individuals who themselves had traveled in Hubei Province or in Wuhan. 2 of the individuals had very close contact, household contact, husband and wife contact with one of those cases. We do not have widespread transmission here in the United States, and we are currently operating under a strategy of trying to delay the arrival of individual cases and to slow the spread of cases should they occur. The CDC has taken aggressive action. We have over 800 staff involved in the response. More than 200 have been deployed around the country. We're carrying out surveillance, laboratory testing. We're supporting responses at 5 military bases around the country where the State Department had carried out charter flights to bring individuals back from Wuhan. We have efforts going on in airports around the country, primarily at 11 airports where direct or indirect flights from China or passengers originating in China are arriving. We're working with the Customs Border Patrol and the Department of Homeland Security in conducting screening to look for ill people and to identify people with a history of travel to Hubei Province. We're also supporting a number of epidemiologic investigations around the individual cases. We have staff in over 60 countries as part of our routine global strategy, and they're supporting the ministries of health in those countries in preparedness efforts and surveillance and detection so that they can be ready should cases arrive. We've been carrying out outreach to clinicians about how to evaluate people for possible novel coronavirus and how to care for them and how to safely protect themselves from acquiring infection in the healthcare setting. Intensive work with our public health partners at state and local public health jurisdictions who are really on the front line of this response. We're, of course, working through the media and with other channels to reach the public so that everyone knows what they can do to protect themselves and their families and what to expect in the weeks and months ahead. We've also been reaching out to the business sector and private sector about their role in this response. Of course, our world is so interconnected that many, many private and public sector institutions have installations all around the world and workforces in many areas. I want to mention 2 updates from yesterday. Today is the 14th day of the quarantine of individuals who were on the first charter flight returning from Wuhan Province. They're currently being assessed to make sure that they remain symptom-free, and then we hope that they'll be released to travel on to their home today. So that's one milestone that we will be hopefully celebrating later this morning. A second update is the first case detected in California in an individual who was part of another group that was repatriated from Wuhan, one of the subsequent charter flights. The individual is being cared for in California, and that person is now our 13th case that has occurred in the 6 different states. I know that everyone wants to know what to expect going forward, what is the trajectory that we'll see with this, and certainly it's in a very intense situation in Hubei Province in China, in several other provinces where the Chinese authorities have taken very aggressive measures to limit transport out of the area and to prepare their healthcare sector to surge with the great increase in cases that's occurring. As you heard, over 42,000 cases in China the vast majority in Hubei Province, where extreme measures are being taken to keep up with healthcare challenges and to support the communities that are pretty isolated right now from the rest of the country. The other event that's been in the news this week is the challenging situation on a cruise ship off of the coast of Japan, where a large number of passengers are currently quarantined, and an increasing number of passengers have developed the novel coronavirus. This is a very difficult situation for the passengers, for their families, and our thoughts really go out to them. I can say that the CDC is working with our U.S. Embassy colleagues in Japan, and the global community is assisting Japan as they try to address the challenge of these passengers. We are learning more and more each day about this virus. We think that in many respects, the spread of the virus is through respiratory droplets, similar to what we see with seasonal influenza, similar to the vast majority of spread of the SARS virus that this has been compared to. But we don't have as much information as we would like about the severity of the virus. We know there are quite severe cases in Hubei Province with fatalities, with people requiring mechanical ventilation, with what we call acute respiratory distress syndrome. But there are also episodes of much, much milder illness. The 13 individuals in the United States have not yet had very severe illness. In fact, most have had very mild courses. We've intensively evaluated them, but they haven't been critically ill. We wish that we could tell you exactly what the next few weeks and months will mean. Our current strategy is really a containment one, focused on our borders and focused on intense evaluation around each confirmed case, contact tracing, prompt identification if they develop symptoms, evaluation of the possibility of coronavirus. But with large-scale spread, as is occurring in Hubei Province, the strategies often need to change. So we'll be looking ahead at how to prepare for a worsening situation. Some of the steps that the CDC has taken have really put us in a better shape should widespread transmission occur here in the United States. Our scientists developed a rapid diagnostic test that has been shipped out to the state laboratories, to a number of DoD labs, and we're filling requests from international labs as well. That can really help put the diagnostic information closer to where patients are presenting and shorten the lag time between when a person presents and is evaluated and when we know what they have. We need to remember that this respiratory illness is spreading in the middle of the typical influenza season. So the vast majority of people right now in the US who have respiratory symptoms like cough or shortness of breath or fever are not infected with this virus. Influenza is a much more likely possibility right now, as well as many of the other respiratory viruses. In addition to the laboratory test, we've been working with the healthcare sector to help them prepare for this. As many of you know, the healthcare institutions and businesses have done a lot of pandemic planning over the past decade or so, and that this is the time to open up your pandemic plans and see that things are in order and make sure that people know what your plans are, for instance, for surge at a hospital, for the ability to provide personal protective equipment for your workforce, at the administrative controls and so forth that you might put in place in your healthcare setting. Other interventions that we've issued have been related to travel. Initially, an advisory about travel to China, then an alert to say to not travel unless your travel was essential, and currently the State Department has issued a level 4 advisory of don't travel to China. The State Department also provided authorized departure for their employees, and of course sent charter flights to repatriate individuals from Hubei, from the hotspot there. The question comes up over and over: how does this compare to the severe acute respiratory syndrome, or SARS? That epidemic affected many countries, hotspots in China, in Hong Kong, in Singapore, in Toronto, Canada, Vietnam. But this outbreak is spreading much more quickly than SARS did. We could see from the pace by which the virus was imported into many other countries, more than 24 right now, that this virus seems to be more transmissible than SARS. On the other hand, the current information suggests this virus overall may be less severe than SARS. Among the confirmed or cases of SARS, it was about 1 in 10 that resulted in death. The current estimate from China of the cases they're aware of is that it's about 2% result in death. But that number really needs to be put in qualifications, because the level of illness is such that they haven't really broadened the ability to track the milder illness, the illness that might not need to present to care. So the transmissibility of this virus may be perhaps more similar to influenza or the common cold, and the novel coronavirus is related to common cold viruses, other coronaviruses. The transmissibility is a big concern for whether containment is feasible. So far, our strategies seem to be working here in the US, but it may be that with additional cases, particularly if they don't involve symptoms or very mild symptoms, that it'll be very difficult to block the spread. When containment doesn't work, our next strategy is really about slowing the spread, delaying the peak of illness. That's been part of our pandemic plans all along, to actually reduce the spread of a virus from person to person. And that can be done with non-pharmaceutical measures like social distancing, having more people telework. Occasionally, we may go to school closures, as we did at the beginning of the 2009 H1N1 pandemic, really trying to reduce crowds and mass gatherings, and really that is what is being implemented in Hubei Province. Another intervention that has been used in large scale in China is the use of quarantine, and that is a strategy where people without any symptoms are cohorted or asked to stay home alone and to not come in contact with others. A quarantine is when you've been exposed to the virus, but you have no symptoms and your movements are restricted. Of course, we have exercised large-scale federal quarantine in this outbreak for the first time in more than 50 years, since smallpox days, and that is really because we were bringing individuals out of the hotspot in Hubei Province with those charter flights, and we're not sure whether it was really safe to release those individuals into their home communities. As I said, the first of the charter flights groups is completing their 14-day quarantine today, and we hope they'll be able to return home later today. Some big picture differences between this virus and previous ones. Transmissibility, perhaps in between seasonal flu and SARS. Severity, perhaps closer to seasonal flu than SARS. Nosocomial or healthcare-associated spread was a major feature of the SARS epidemic, with large outbreaks in hospitals, both affecting patients who were already hospitalized for other conditions, frontline nurses and doctors and healthcare workers who were caring for patients, and family members who were in the hospital helping their loved ones weather an illness. Nosocomial spread of the novel coronavirus has been reported now, a report out of Wuhan from a large hospital series where 40% of the cases in one hospital were estimated to have been acquired in the hospital, both from patients already on a surgical ward or from the healthcare workers that were there. We don't know how large a feature nosocomial spread is with this novel coronavirus, but that's one of the reasons it's so critical to prepare the healthcare sector to take precautions for the healthcare workers and for other patients. Another feature of the SARS epidemic was super spreading events, sometimes in hospitals with large-scale outbreaks when there were aerosol-producing activities, and sometimes in the community, as we saw with the Metropole Hotel in Hong Kong, where individuals who stayed in the same hotel the same nights as an individual who had become ill from Guangdong became infected and brought the virus back to a number of other countries. The Amoy Gardens outbreak in Hong Kong was an apartment complex with a very explosive outbreak that was quite different in its transmission properties than what we saw in most of the rest of the SARS outbreaks. So we're in early days of fully understanding all of the ways that the novel coronavirus can spread, and we're taking aggressive measures to protect Americans and to support colleagues around the world, learning every day and trying to translate that learning into updated guidance. CDC's issued guidance for the healthcare sector, for cruise ships, for emergency medical teams, for state and local public health, for travelers, and will continue to do so. I think that we've seen a large role of the World Health Organization in this response, and I want to make a few comments about the international health regulations and the way that we work as a global community. One of the legacies of the SARS outbreak was that there was a cover-up, there was no transparency, and we lost critical time with the virus spreading to many other areas before we realized how bad it was. After the 2003 SARS epidemic, the WHO worked with member nations to update the International Health Regulations, or IHR. And the idea there was we didn't want countries to keep things secret. We wanted them to be transparent and report as quickly as possible whether there was a problem that might turn out to be worse, to not have penalties for prompt reporting, but to really promote openness. As we've seen with Ebola outbreak and with the current novel coronavirus, WHO and its emergency committee have been in the spotlight about whether they were declaring a public health emergency or whether the Director General was or not. This has been declared a public health emergency of international concern. The exportation of a severe, potentially severe virus to many countries certainly raised that threat. But I think we're learning more and more about how complex it can be to fully understand a rapidly spreading respiratory infection. The Chinese promptly identified a new virus that had never been seen before in humans, posted the whole genome sequence for other researchers or countries to use, and we were able to use that sequence for diagnostic tests to be developed and distributed rapidly. But of course, there's lots of criticism about could we have done more sooner? Did we understand fully how this was spreading? And it is very frequent in serious outbreaks like this for there to be lots of blame. What I want to say is just my commitment as a U.S. government leader and as part of the Centers for Disease Control and Prevention, that we're committed to transparency, to tell you what we know when we know it, to provide as accurate information as we have, and to tell you what you can do to protect yourself. The virus in this case is often seeming like it's spreading faster than we can keep up with it, but again, the US situation is very different than what we're seeing in China right now, particularly in Hubei Province. 13 confirmed cases, only 2 individuals acquired their infection here in the US because they were essentially the partner of an individual who acquired the infection in Wuhan. Our aggressive measures with our travel and border strategy and our contact tracing and investigation, release of the lab test, support of the repatriation flights has slowed the arrival of this virus, and we're working 24/7 to be ready for any worsening that occurs. I think with that, I actually want to make one more comment about a comparison between the novel coronavirus and many of these emerging infections in the past. The role that research can play is often very contentious, whether we need to respond to an outbreak or we can actually take the time to research interventions. In the 2014-15 Ebola response, we learned that it was possible to carry out investigational vaccine research in the middle of a terrible epidemic. And because that was done, we really actually now have a licensed vaccine against Ebola and a vaccine that was available to be used under investigational new drug use in the DRC Ebola outbreak in 2018 through the present. Currently, there are drug candidates that are being tested or considered for use in this current novel coronavirus outbreak, and there's vaccines that the NIH and others are considering development of. I think it's really important for us to be able to do both, to recognize that the pace of research can keep up sometimes and really needs to be not an afterthought, because we don't know how long some of these new emerging infections will persist. And there are many new technologies that make such research much more rapid. That said, the ethics and the scientific accuracy and quality of research is always really important. Here in the US, we have individuals under federal quarantine. We have investigations in the 6 states where cases have been confirmed, and we are trying to learn as quickly as we can about ways to slow the spread of this virus. But we know that medical countermeasures like drugs and vaccines may take time. So I think with that, I'll turn things over to the moderator for questions, or back to you, Mr. Friedman.
Thank you, Dr. Schuchat. We're pleased to take your questions now. Aaron will be bringing the microphone to you. So why don't we start up here? We are going to ask that the journalists who are covering the event be allowed to ask their questions for the larger audience.
Okay.
Thank you. Please.
Thanks. Hi, Dr. Schuchat. Joyce Frieden from MedPage Today. I wanted to ask how you would advise doctors who are trying to calm patients who might be worried about this, and also if you could go a little into more the 2% mortality rate versus the 1%, because it sounds like it's more, but as you're explaining, it isn't necessarily what it looks like compared to SARS.
Versus the 10%, yeah, okay, yeah, okay. Yeah, SARS was 10% about, yeah. And then, and this, well, the preliminary data from China is a little higher than 2%. But of course, we have 0 out of 12 here in the US so far. And there, the percent fatality among the individuals around the world, not in China, is much lower than the 2% out of China. That may be because we have such alert systems that we're picking up patients at a much earlier stage, or patients who were never going to progress to the severe pneumonia that was the tip-off of this problem in China. So what we like to do to really understand the mortality or the case fatality ratio, the proportion of infections that will result in death, is a larger scale assessment of both mild illness as well as severe illness. The initial tracking, understandably, was looking at people presenting with pneumonia who required hospitalization, and that would always be the more severe end of the spectrum. The issue for clinicians is a real one. We know that whether it's the acute flaccid myelitis, AFM, scary polio-like illness, or the H1N1 influenza at the beginning of the pandemic, anything that's novel can be scary before we know a lot about it. Zika, Ebola, of course. The circumstances in the United States are such that we have excellent surveillance for influenza, and we are aggressively looking for cases that might be the novel coronavirus virus, and so far have only identified 13 individuals. People who have cough and runny nose or fever are much more likely to have a normal, common respiratory virus right now. Now, if you're presenting after travel to Hubei Province or after return from China, we want travelers to have their alert up and to let their clinicians know, I was recently traveling, they may need special evaluation, and the clinicians may need to take special precautions when they collect samples from them. So we've updated our recommendations both for diagnostic testing, for workup of individuals, as well as for protection of the healthcare workers. It's a critical issue. Right now, we're trying to find every single case of this novel coronavirus, but as I said, 13 versus the millions and millions and millions of cases of influenza that we've already had this season. Do you want to?
Yeah, we're going to come over to this side for a couple of questions, and then we'll come back around here. Please.
Doctor, thank you for taking the question. Marty Van Dyne with NewsNet News. I have a quick question. This weekend at the National Governors Association, Hawaii's governor mentioned that their concern was that they had to send the test off to the CDC, which took a lot of time. And you just said that you have now got these tests out to all of the states. Does that include these, the ones outside the continental United States and our territories, such as Puerto Rico, Marshall Islands, all of those places?
Yes, that's right, and we've shipped kits to Hawaii, so for sure. We have, CDC has set up something called the International Resource Reagent Facility, the IRR, and that's a means by which appropriate laboratories can order reagents for this test. The test has received an emergency use authorization approval from the Food and Drug Administration and can be tested now at these state laboratories, as well as we're filling orders from other countries and from DoD labs around the world. So yes, that question from Hawaii, we have, I actually have confirmation that Hawaii's tests have been shipped, so sure.
Okay, we're going to come up here.
Thank you. Sam Husseini from Consortium News. Obviously, the main concern is how to stop the virus and death and so on, but I think that we should look into the origins of this. Is it the CDC's contention that there's absolutely no relation to the BSL-4 lab in Wuhan? The town, it's my understanding this is the only place in China with a BSL-4 lab. We in the United States have, I think, 24 or so, and there have been problems and incidents. Some of them have been shut down out of concerns of leakage of potential pathogens, and it's an ethical struggle in the United States about gain-of-function research. That is, research that actually attempts to make pathogens more lethal. And China is a very opaque society, a totalitarian regime. We have no idea, or I don't know, you tell me, do you have any idea what kind of research could potentially be done? I'm not contending that this was intentional in any way. I'm just asking, is it a complete coincidence that this outbreak happened in the one city in China with a BSL-4 lab, and shouldn't we be having at least some of the discussion about the ethics of some of the research that happens here? Thank you.
Yeah, thank you for those comments. Based on everything that I know about what is going on with this outbreak and the research that's being conducted, as well as the genomic sequences that have been posted and the comparison with animal strains, this, the pattern that we're seeing is quite consistent with emergence from animal to human acquisition and adaptability or mutations that permit the virus to be easily spread between people. There's some emerging research about, the virus itself is related to bat viruses, as was the SARS virus and the MERS virus, but there was an intriguing report about pangolin sequencing, an animal that is apparently a large part of the wildlife trade around the world, with 99% similarity, but what our scientists tell us is you actually need more like 99.9% similarity for us to understand origin. The animal origins and the circumstances of the emergence of this virus are really important to understand, and it's one of the key questions that the global community wants to look into. In terms of the question about gain-of-function research and laboratory issues, very important for us as a scientific community to have practices that protect researchers and their laboratory workers as well as the community around them, and that we use science for the benefit of people. So I am closely involved in this response, and everything that I've seen so far is very consistent with the animal to human spread that we've seen in other zoonotic origin.
On that, I mean, the two things don't necessarily preclude each other. That is, the Chinese lab could well have acquired the bat.
Yeah, let me make a few, sure. Let me just,
1,000 miles away, the
yeah,
place where the bats are.
yeah.
That's virtually the cause. So the two things aren't mutually exclusive, are they?
Yeah, let me make a comment. Information is critical, and having the very best information available to those who, to everyone, to be able to protect themselves, their families, their communities is essential. In the midst of new infections, it is very common for rumors to emerge that can take on a life of their own. So as you mentioned, a laboratory and the center of what else is happening in that province, I'm reminded of concerns we heard when I was in Sierra Leone in 2014 with the Ebola response. There was a concern that there was a hemorrhagic virus research center in Sierra Leone, and maybe that's where the virus had come from. It was a key rumor that had to be overcome in order to help control the outbreak. So based on everything that I know right now, I can tell you the circumstances of the origin really look like animal to human. But your question, I heard. So
Thank you.
Dr. Schuchat.
Danny, please, go ahead.
Dr. Schuchat, MedTech Insight. Danny, you talked earlier about talking with the private sector. I wanted to kind of understand, have you been talking with medical diagnostic and device companies about what they can do to try to assist in this? And if so, if you could provide any details, and also if you have any details on stockpiles of medical devices and diagnostics that can be used either to share with the Chinese or in the U.S. If things escalate.
yeah, thanks for those questions. One of the benefits of the modern communication and technology is the ability to share new information rapidly. So because the Chinese promptly posted the genetic sequence of the virus, others were able to develop diagnostic tests. The CDC has actually both posted the sequences of the viruses that we've gotten from the cases here in the US, but we've also prepared viral isolates that can be ordered by research companies, and that is through the BEI system that NIH runs. So we think that it's critical for the private sector to get in on the diagnostic development. The laboratory kits that CDC developed are really just the start, and commercial scalability of those will be quite helpful. The issue for medical device manufacturers, medical companies in general, is both they can be a huge help here, but we're aware of how interconnected our supply chain is. And there may, it's not just the medical devices, it's, your smartphones as well. And that Hubei Province is a big industrial center, and that China, of course, is a huge producer of a lot of goods that are used as parts. So there's a lot of work right now going on to understand supply chain and vulnerabilities and try to address them. And in terms of, I really don't have more information about the stockpile to talk about, but I can tell you that a key principle is to use the scarce materials where they can be most helpful and not use them where they're not needed. We've seen sort of a run on face masks in the, or on N95 masks in consumer stores, and the real thought about the N95 masks is those are really most needed in the healthcare setting and not, of course, not in the community right now. We're not seeing community spread here, and we don't think that the N95 respirators are really necessary or useful, but we want to make sure we have what we need or can use what we need as appropriately as possible.
Thank you. We have 3 questions, I think, straight across here. So you have the microphone first, please.
Thank you, Dr. Schuchat. Eunjung Cho with the Voice of America. Yesterday, WHO's international team of experts, advanced team, arrived in China, comprised of 3 members.
Right.
And Dr. Tedros said that a larger member, a team would go as soon as possible. That would be around 10 people. There were speculations that a CDC expert could be included in this WHO team. So could you tell us about the plan for an American expert to be included in that WHO team? And if you could share with us the conversations with Beijing to send international experts to China, and what could be some of the areas where China could benefit from American expertise in containing this disease? Thank you.
Yeah, thank you so much. CDC has provided names for the WHO team, and we are usually part of WHO teams. In fact, in 2003, I went to Beijing during SARS as part of working for CDC, but as part of the WHO response team there. It can be very helpful to have outside experts arrive in the midst of an epidemic like this. Usually the public health leaders and the researchers and clinicians are so busy with that frontline response that having some fresh eyes, perhaps who have not lost as much sleep over the past month as the individuals in China, can be helpful. I can say in 2003 we were able to help launch a series of studies that helped understand super spreading, helped look at risk factors among people who didn't have a link with a case, so that the critical assessment of what the transmission is, additional evaluation of the severity, very critical right now for us to understand all the different routes of transmission, the full severity, which can help us with our models of what the impact may be if this becomes spread to many countries. And then following up on the other question, really understanding potential animal reservoirs, because if this did emerge from animals, it could do that again, or it may continue to do that. So those are the types of things. Whether there's effective strategies, one of the things will be, are the measures that are being taken having an effect? Are some a big effort but not as effective as others? And how can we better control what's going on in China and also learn from that for others?
But what is the specific area that America has more expertise than China? And is China being receptive to American offer to send experts there?
My understanding is the latest discussions that there's been receptivity. The issues of different types of expertise, there's a lot of great scientists in China, excellent individuals in public health. Sometimes outside evaluators can either confirm an excellent response or find gaps that might help with strengthening things. I think that China has been working tirelessly in this response recently with these very intense efforts around Hubei and other provinces that have now pretty much walled themselves off. And I think whether it's our epidemiologists, virologists, infection control experts, quarantine experts, the U.S. has a lot to offer, as do other countries.
Hi, Anson Mercer with the Asahi Shimbun. So I kind of want to direct our question more towards the cruise ship off the coast of Japan.
Yeah.
So there have been increased cases. Firstly, there was the case of, it was, I believe, 61 cases on the ship, and then it jumped to 135. So I'm kind of curious on, with DHS and DoD being able to construct these the housing for people on all these Air Force bases, and China being able to build hospitals over, day and night. Why hasn't there been any effort by either the Japanese government or instruction from U.S. CDC or U.S. officials to build on land, basically quarantine areas for these people on these ships? Because from my understanding, it seems that people are just going to keep on getting sick on this cruise ship. There are more people on the ship that have the coronavirus than are actually in mainland Japan. Is this a policy thing that they don't want people on their homeland, or is it something else?
The information that I have is that there's an openness to understand what's the best way to care for the individuals who are on the cruise ship, reduce the risk that they will acquire the infection if they haven't already acquired it, and to protect those around them. And so the initial plan of quarantining those who weren't ill on the ship so that they could complete their quarantine isolated in individual rooms was the strategy that the Japanese were undertaking. I would say that the increased case count is making authorities really look critically at what's the safest thing, the best thing. As I said, I believe it's a cruise ship with a lot of elderly individuals, a lot of people with underlying conditions. And from what we've seen in Hubei Province, The severe outcomes, the fatalities and the life-threatening respiratory failure are predominantly occurring in older people and people with other medical conditions. And so this cruise ship is filled with people like that. What's the best way for them as individuals, and what's the best way to safely offload them if they're going to be offloaded?
Sorry, so follow up. But in your opinion, what's like the tipping point for when when that situation will change? Like, is it going to be a fatality that's going to need to get people off that ship?
I don't think there's a tipping point. I think the issue of what are the options available, and that finding the best option, given what we know right now about how much spread has already occurred and whether how many are still susceptible. So I think it's just a really difficult issue, and honestly, for the passengers, the crew, and their families, it's extremely difficult.
Hi, Michael Nettleman from CNN. I have a couple questions about the most recent US patient who originally tested negative, was released from the hospital, and after subsequent testing was found to be infected with the virus. I guess, do we have any sense for how much contact that patient would have had with others on the base after being released from the hospital? And I'm curious to know if subsequent testing, was that already part of the protocol, or was there a specific reason that that testing was performed? And then the answer, the result, has that informed or changed kind of how CNN is approaching testing about this virus?
The contact investigation is ongoing. The preliminary information I had was that there was very limited contact. The individual, when they developed symptoms, really took precautions, but I think that's being reassessed at this point. The issue about the laboratory test, let me make some general comments and then speak specifically. I think there's a lot of questions out there. Is it an accurate test? Do you have to do tests over and over and over to find infections? With other cases around the country that we're evaluating, we have been doing serial tests to understand whether they're still infectious and in what, whether through respiratory means or otherwise. So there is some information about changing results over time. In this circumstance, that's not what happened. It turns out there was probably a mix-up, and the original test wasn't negative. But there's been a new test collected in order to understand whether the person is still symptomatic. So there was a little bit of a mix-up there.
Can you explain a little bit more about what the mix-up is?
That's about all I have. Mm-hmm.
Good morning, Carmen Heredia Rodriguez with Kaiser Health News. You mentioned this a little bit earlier, but can you talk a little bit more about the difference between the mortality rate that we're seeing in the Chinese province versus the rest of the world?
Sure. You can imagine if all you're looking for is patients who need to be in the hospital, that the number of those patients who have a life-threatening or fatal illness will be a higher proportion of the total than if you're looking at everyone in a neighborhood or everyone in a province. And so the surveillance definition and the ability to look for cases will affect what you think the fatality is. At this point, the rest of the world has, let me just see if I have the numbers. I think there's 464 cases reported now outside of mainland China, and I can probably get you the numbers. I think that of those, of those, there's only 2 that have been fatal. Now, one other issue is timing. And the first day of an illness doesn't tell you the percentage fatal. There's usually a lag of a week or 2 weeks, perhaps, between a person being detected with the illness and understanding how severe that's going to be. So, of course, the situation in Wuhan and Hubei Province has a several-week lead on the rest of the world. And the 400-some cases we've been seeing in other places are not as far along in their recovery as the individuals in China. So part of it is where you're looking. Are you looking for mild illness? If you're not, you might exaggerate the mortality or the case fatality. And a second thing is the time to make sure that you give a chance to see whether those people will recover or not. My understanding is that they updated the case definition to not require hospitalization and not limit things to pneumonia. But you can imagine when you have a widespread outbreak and a limitation on the throughput of your laboratory testing, that that you may not be keeping up with the new numbers. And in fact, you can say, even look at our seasonal influenza. When we have tens of millions of cases each year, we're not recommending that every single one get a laboratory diagnostic. What is often done is modeling, to take the different parameters that we have and estimate based on that, what do we think the true mortality is. So with influenza, it's not based on the deaths reported that we calculate the number of deaths. We do that based on modeling from many different data sources.
Hi, David Lim with Politico.
Okay.
Thank you. I wanted to wrap back around to the people who are being potentially released from quarantine later today. None of those people on those flights were diagnosed with the coronavirus, is that correct?
That's right. The first flight is 195 individuals, and they'll be completing 14 days since they left Wuhan. They were, of course, evaluated or screened, clinically screened before they got on the plane, when they landed in Anchorage, before they landed, once they got off the plane in California, and have been monitored closely during this 2-week period. And at this point, none of them have come down with the virus, and we think that's good news. As we said earlier, there is one individual in one of the other charter flight groups that was just confirmed with disease recently. And so it's been more than 800 people brought out of Wuhan on 5 different charter flights. And yesterday announced the first individual who's been diagnosed with the virus. Again, we're not seeing severe disease yet in the United States, but those are the numbers for our repatriation flights.
And then you mentioned medical screening for those people potentially being released today. Does that include a RT-PCR test of those people?
No, the testing is clinical. They're not. We're not using PCR as a all clear. We're using the idea that the 14-day estimated really outer limit of an incubation period has been passed without them becoming ill.
Dr. Schuchat, there are obviously a lot of questions for you. Your team indicates that if you're willing, you could stay on a few more minutes to answer some questions, so we could get to some more. So just so you know, even though we're coming up on 11 o'clock, we'll continue the Q&A for a few more minutes. We have a question over here, then we're going to move over to this side.
Hi, this is Jessie Hellman with The Hill. There was right here.
Oh, thanks. Right where the light is. Right. Okay.
There was a study in the New England Journal of Medicine that CDC officials cited as part of their reason for the quarantines, but it later came out with German health officials pushing back on the potential of the asymptomatic spread of a particular patient. Later came out that she was showing symptoms when she spread the coronavirus to other people. Does that have CDC officials reevaluating or rethinking the quarantining practice?
Thank you. I wouldn't say that report was the principal reason for the quarantine. Remember that individuals, the first, that charter flight that is being, where the all clear is being announced today, was coming from the hotspot, from Americans being brought out of Wuhan during a period of intense acceleration of the outbreak, and the concern that many of them might be incubating the disease was really the reason that they were placed in, first placed at the base, and then federal quarantine was issued. I think we're still learning about asymptomatic infection and about whether that's a key driver of transmission. There are now reports from other areas of extremely, there's people with very mild symptoms or perhaps subclinical that may have spread to close contacts. And so Every day, more information coming out. There's a couple interesting circumstances in a few different countries that are being looked into in more detail. And as you say, in Germany, the further investigation interview of the individual index case suggested that she did have symptoms when she was in contact with the others in that workplace.
We're going to move over to this side.
Firstly, thank you for taking time to update us all on this. China has been both praised for trying to control the spread of the outbreak and also treat as many patients as possible, and also criticized for not being transparent enough, especially once the U.S. travel ban kind of kicked in. As a health expert, I'd like to get your reaction to that. And secondly, after the Ebola outbreak, the Obama administration appointed a point person for the White House to deal with pandemic outbreaks. The Trump administration did away with that person. Would that have benefited you? And secondly, as I understand it, through House testimony last week, CDC is facing like a 20% budget cut this year if the budget's approved. In light of what's going on, how would that affect you?
Thank you. Now I can't read my handwriting. Okay, the first question was about the criticism of China, right? The situation in China is complex. I think we need to be grateful at the speed with which scientists in China posted the genetic sequence and the extreme measures that are being placed in Hubei Province have probably delayed the spread of this virus to other areas. There are not many parts of the world that could take some of these measures that they have taken, and that has probably slowed spread or limited the widespread transmission of the disease to selected provinces in China. So that aggressive move has probably been quite helpful for other countries. I think the issue of who knew what when is always a question, and whether earlier response could have made a difference is important. I think when you review the numbers, just important as a respiratory epidemiologist and physician to say, it's pretty hard to recognize a new respiratory pathogen in the middle of flu season. That is not a usual thing that we do. The 2009 pandemic, the first 2 cases were identified essentially because we had a collaborative research project going on in San Diego where a person with mild illness was found to have this novel strain, and because we had an intense border surveillance of infectious disease project going on. So it was really the needle in the haystack that found those cases that came, that got sequenced and that we knew was a new virus. So the clustering among people who had a work history or visited the seafood market there was an important clue that something kind of different than seasonal flu was going on, and then that prompt sequencing and posting. Now, was there some awareness among some authorities that there was much more spread, or was it confusion because of the respiratory flu season? I can't say. I just know that the scientific actions and then this border work that they did has really helped the global community be able to prepare. You also asked about the Ebola czar, and we do have a task force that's been set up that Secretary Azar, Secretary of Health and Human Services, is leading, and that task force is meeting every single day and looking at the assets across the government and queuing up new information and policy decisions. And I would say that, as a person who's worked for the Centers for Disease Control and Prevention for 32 years now, almost 32 years, we are in constant contact across the federal government, as well as with our state and local public health colleagues who are really at the front line of preparedness for further spread. Now, lastly, you asked me about the CDC budget, and I can say that the investments in protecting Americans through the CDC's budget appropriation are vital, that those dollars save lives, that the state and local public health infrastructure is often fragile and sustaining it is important, and that I tried to make clear in my opening remarks that while we practice and prepare for pandemic influenza and for other disease X scenarios, Every new threat is different, and we need a strong infrastructure to be able to be nimble and rapidly turn information into evidence-based policy actions. Thank you.
Hi, Lauren Neergaard with AP. Couple of questions on both the quarantine and the testing. So is 14 days really the right amount of time? It seems like the median onset of disease is much shorter. On the other hand, there have been some discussion about outliers out to 24 days, and are those real? And then with the test, you said you're not doing serial testing, but I wonder, what do you actually know as far as from time of exposure to when the virus can first be detected, and after symptoms end, how long is virus shedding going on?
Yeah, thanks. A couple great questions there. The 14-day quarantine was established based on really the outer limit of what was believed for SARS or MERS, the similar coronaviruses, not that similar, but the closest human related viruses. But we've been learning a lot as a scientific community, and I would say that the duration of necessary quarantine is one of the things that we're relooking at, trying to understand, does it need to be that long or not? And then there's that intriguing report for which we don't have good understanding about some sort of over 20 days. I think it's really premature for us to understand what that's based on and whether that may be missed links or some unusual kind of transmission. So we try to incorporate emerging information rapidly. I think CDC is in touch with dozens of modelers around the world, and our own modelers really comparing the information from each of the countries that's studying their cases, as well as the China data, to try to understand how soon people, what is the interval between exposure and illness? What is the interval between infection and another infection? Two different parameters, and then of course this reproductive number that we keep talking about, which is the transmissibility. Now in terms of the serial testing, let me clarify. I wanted to say in the repatriation group, the group that came out on the charter flights that are asymptomatic, we're not doing repeated testing on them. But in the individuals who are confirmed cases, we have been following up with testing to understand whether there's persistent viral shedding and at what site. And that can be quite important in understanding when maybe a person's well enough to not have to stay in the hospital. If they go home, what kind of precautions need to be taken in the home so that other people who live with them are not exposed. But that question of between exposure to infection, when does the virus appear? There's lots of different thinking right now from the anecdotes of the different countries' experience. Is there high viral load early, which was not the case with SARS? SARS, a key thing in SARS was you were most contagious when you were really sick, and that's why we had those hospital outbreaks. There's questions now with some of these individual clusters. Are some people more infectious early on before they even realize they're that sick? So I think those were your questions.
We have a question here, and then we're going to come back here.
Hello, hi.
Okay.
Simone Gao was zooming in NTD TV. Some of the people have already touched upon this, but I just want to dig a little deeper. So when CDC make assessment of the epidemic, does it take into consideration that the official number from the Chinese CDC might still be very severely underestimated? Because, for example, the Chinese medical officials admitted that medical personnel admitted that the diagnostic kits they need to use to test the patients are very limited, only 10% of what they actually needed. And also we did an interview with one of the funeral homes in Wuhan city 2 days ago, and they said they have been absolutely overwhelmed. And they've been basically working 24/7, and 60% of the bodies they cremate are actually from home, 30% from hospitals. Obviously, those 60% of the bodies are not counted in the official number. So that's one question. Is it still very, very severely underestimated? And question number two is regarding the quarantine center in China. We know China has this policy right now. If you have a symptom it doesn't matter if you get a flu or anything else or coronavirus, you you are forced to those quarantine centers. We have seen footages of this Fangchang quarantine center with 1,000 beds, like very close to each other. So my question is whether those will actually increase the possibility of cross-infection, or is it an effective way to control the spread of the epidemic? Thank you.
Yeah, thanks. Those are both really, really important questions. We absolutely assume that the reported cases are an underestimate. The early exportation of virus to a number of countries was used by mathematical modelers to estimate what the total cases must be. If we knew of 41 cases, but this many countries were seeing cases imported among travelers using the known numbers that travel, there were some estimates of under-reporting. And, it's a mix of not hiding cases, but really trying to keep up either with the mild cases or, as you say, now that the disease is so common that the laboratory capacity can't keep up, or the kits aren't, there's not available kits. So we absolutely assume there's a much greater number of cases. And China's actually reporting what they call suspected cases, ones that haven't yet been tested. And then that's typically, how we assess outbreaks and emerging infections. Your question about the quarantine center, theoretically a quarantine center should be people who have no symptoms, who are being observed to see, because you think they're higher risk than others because they've been exposed, you want to observe them, and at the first sign of symptoms, you want to move them out of exposure to anyone else so that they can be isolated. The concern about putting people who may be ill together could be a problem in terms of acquiring the infection. People who go in for something else like influenza or measles and then come down with the novel coronavirus. So that's why the circumstances of isolation are so critical. It's one of the reasons I believe that China built those hospitals with individual rooms so that they could keep people they knew were sick separate from others and safely care for them. But the ability to surge for a very large-scale outbreak can be challenging for anyone.
Dr. Schuchat, thank you for the extra time. We have 2 more questions in the back, and we'll wrap it up.
Hi, my name's Eric Egan with the Confucius Institute U.S. Center. Earlier, you were talking about how you were coordinating with the business and private sector to identify their role in helping combat the spread of the virus. As a nonprofit that focuses on Chinese language and education and cultural exchange, I was wondering if you've identified any places in which language differences or cultural differences may be creating barriers towards helping fight the spread of the virus, and if there's a space in which nonprofits like ours are able to get involved and help either through translation or community outreach.
Thank you. The communication aspects of an emerging infection are really critical to both understand concerns and communicate effectively to the different groups. We know that there's lots of rumors. We know that there's lots of channels for communication in many different communities, and language barriers can be important. So obviously this outbreak is occurring in the context of not just 24/7 news, but social media on a level that probably many of us couldn't have imagined when we were dealing with SARS in 2003. And so those who can rapidly identify the new threats or the new concerns, sometimes, WHO's done rumor monitoring for years, trying to have an early recognition of problems before they may get officially reported, but sifting through rumor versus verifying them is challenging. The other thing is getting good information through trusted channels is quite important to affected groups and those who are indirectly affected. We know that in many outbreaks, different populations become stigmatized, and that's a thing that we're already worried about, here in the US, around the world, that somebody coming back from this community or that community may be treated differently when they try to re-enter the school or workplace, and that businesses in a certain neighborhood might be boycotted. And so I think the language and cultural competence of an organization like yours can be an asset to this type of response.
Thank you.
This is from Sound of Hope Radio Network. My question is, from yesterday, the co-chair bipartisan commission on biotechnic, former Senator Joe Lieberman said, I heard that President Trump and President Xi has a Power One conversation, much of which was about coronavirus and how to better deal with it. And we heard from Secretary Pompeo's Twitter that U.S. has sent many supply of materials to Hubei, to China. And we also heard from Senate Tom Cotton that he doubt the coronavirus came from Chinese biotechnic library, which I read this is a report from CNN. I read the news from Epic Time yesterday that this kind of biotech library was controlled by Jiang Zemin, the new old CCP's leader, Jiang Zemin's son. And we also know Jiang Zemin have got power from Tiananmen massacre during 20 years, and so many human rights violations like the Christian, Tibetan, Catholic, Falun Gong practitioners has been persecuted by this false Christian. Yeah, and we heard my question, was recontrolled by the new leader, Xi Jinping. So in your view, is this about change toward the effective containing to the virus? And in your view, what next step you suggest to to stop and cure the virus? Thank you.
Yes, thank you. I think what I can say is that the U.S. is working closely with the World Health Organization and countries around the world, including China, to better understand how best to control the virus, both in China as well as elsewhere. And it's a critical time. The U.S. has been a leader in public health preparedness and understanding of respiratory viruses like influenza and SARS, and we're trying to be a help to other nations as well while we prepare the U.S. for what may become worse here. Thank you.
Dr. Schuchat, thank you for joining us, and thank you for giving us so much time. As a token of our appreciation, we would like to present you with our National Press Club coffee mug, something that may come in very handy over the coming days and weeks. Thank you again for joining us, and good luck.